Welcome, everyone. We're just waiting for folks to trickle in, and we'll get started in a minute or so. Good afternoon, everyone. I hope y'all have your lunches ready as we learn about some exciting Supreme Court and Washington State cases and protections. We'll get started in about a minute. All right, good afternoon, everyone. We're going to get started. Just a quick housekeeping before we jump in. There is not a chat for attendees, but please, there is a Q&A box that should be at the bottom of your screen. Please do feel free to use that. We will have hopefully time, 10 minutes at the end for question and answers with all of our panelists. Today, I'm so excited to present our slate of expert speakers. I'm going to start with Lichi P. Leong, who is the Senior Policy Advocate at Northwest Health Law Advocates, also known as NoHLA. We have Emily Bryce, the Deputy Director at NoHLA. Leah Ruttman, the Health Policy Program Director at ACLU of Washington. My colleague, Julia Marks, the Washington Litigation Attorney with Legal Voice, and myself, Alize Bojani, the Washington Policy Counsel for Legal Voice. Thank you so much for everyone here. I think we have about 40-ish people in attendance, and maybe more will trickle in as we continue going forward. We're going to talk about the 2 years post-Roe current reproductive health landscape. Arithi, if you wouldn't mind starting the slides. Oh. Thank you. Perfect. We're going to talk today about what the overturning of Roe v. Wade in 2022 with the Dobbs decision dramatically did. It changed the national landscape for bodily autonomy. We are seeing consistent new attacks on abortion rights, LGBTQ+ rights, particularly those of trans people, and judicial activism spreading a right-wing agenda that is not rooted in laws, science, or good policy. This is why we are here today, to both understand what is happening on the national level and what we can be doing in Washington State so that we are not only being reactive to attacks, but proactive in access and care where we live. So today we're going to start with an overview of the post-Roe landscape for bodily autonomy nationwide. Then we'll discuss 3 key SCOTUS, Supreme Court of the United States cases, and then end with a focus on Washington protections and litigation, as well as contraception access. So I hope this is what you signed up to hear. I'm going to pass it to Lichi to start us off.
Thanks so much, Alize. We can move to the next slide. So I think we can agree that everyone should be able to get the care that they need, and that ability should not depend on your zip code. Unfortunately, across the US, people who need abortion are navigating confusing webs of state restrictions. Since the 5-decade foundation of constitutional protection for bodily autonomy was taken away, each Supreme Court case prompts more chaos and understandable fear. In the days immediately after oral arguments in the suit seeking to usurp the FDA authority, the reproductive helpline at If When How saw a 70% increase in inquiries, even though no laws had changed. Within roughly 2 months, 17 million women lost access to essential reproductive health care because extremist politicians continue to introduce increasingly cruel legislation. We'll move on to the next slide. This shows us where we are today. It's important to note that even when Roe still stood, almost 8 million women couldn't access abortion due to federal funding restrictions. They already had to take extraordinary measures to make decisions about their pregnancy and their health. But as you can see from this patchwork, access has moved further out of reach for tens of millions more. The blue states on this map have actually expanded access, and teal states have protected access. Few yellow states don't have protections, while the red states are actively hostile. And the 14 burgundy states have made abortion illegal. It's completely banned in those states. A total of 21 states have abortion bans. In these states, more than 1 out of 3 women of reproductive age live. Several others have rendered abortion care practically unavailable by criminalizing the provision of that care after the earliest weeks and forcing people in most of those states to remain pregnant against their will. Over 300 bills and 4 national bans have been proposed. All this despite the fact that the majority of people in the United States support abortion rights, even in states with bans. We've seen that this is not the will of the people. Since Roe was overturned, every state that put abortion on the ballot has voted in favor of access. States like Ohio, Michigan, Kansas. But extreme politicians continue to push their agenda and try to usurp people's personal ability to make medical decisions with their own opinions. We saw in Alabama, the state Supreme Court threatened access to IVF, and Louisiana's legislature passed a first-of-its-kind law classifying mifepristone as a controlled substance. You'll hear later from our colleagues at Legal Voice that these laws aren't just cruel, they also create obstacles to maternity care, even with today's EMTALA decision. These attacks exacerbate existing disparities. We can see on the next slide that those disparities aren't limited to only abortion care. This map illustrates another aspect of bodily autonomy. In 18 states have passed laws against gender affirming care. An estimated 37% of trans youth ages 13 to 17 live in these states that ban best practice medication and surgical care for youth. The 15 green states, which include Washington and the District of Columbia, have shield laws protecting access. And in fact, you can see 2 little shield symbols that indicate that protection existing through executive order. Note that Arizona both bans best practice surgical care for trans youth, but also has a shield law via executive order, just part of the confusing complexity that we're all navigating. The states indicated in beige have neither a shield law nor do they ban best practices, but the orange states indicate that bans prohibit both best practice in medication and surgical care for trans youth, though not all those bans are in effect. And the red states actually make it a felony to provide certain forms of best practice medical care. So this encompasses more than abortion. This landscape has been increasingly challenging for those of us who think that we should make decisions for ourselves and our bodies. And with that, I'll hand things over to Julia to talk about some key national cases.
Thank you so much, Lychee, for that great overview. We're going to turn now to 3 cases that are really important nationally for abortion access and access to healthcare more generally. I'm going to start us off by talking about FDA versus Alliance for Hippocratic Medicine. Next slide, please. So this lawsuit is probably most commonly known as the mifepristone case. Just to set the stage, this is a lawsuit challenging the FDA's approval of mifepristone, which is one of 2 medications commonly used to provide medication abortion. It was brought by conservative anti-choice doctor groups in Texas who were challenging both the original approval of mifepristone way back in the year 2000 and changes that the FDA has made over the last 5 to 10 years that make it easier for doctors and other types of healthcare providers to prescribe it and make it easier for pregnant people to access it. That includes getting rid of an in-person clinic visit requirement. And this attack is really significant for a few reasons. First of all, medication abortion is an increasingly common way that folks in the United States have abortions these days. So it's estimated that 63% of abortions in the formal healthcare system here are actually medication abortions, and this percentage has been growing. It's also really an important option for people who face different burdens and constraints that make it extra challenging for them to get abortion care. So that could be difficulties traveling if they live in rural areas, cost barriers, challenges with getting assistance for childcare or time off work. For survivors of domestic violence, they might prefer medication abortion, feel safer using that method. And then for folks in states where it bans access to medication abortion is a really important way they can still access care. And that might be traveling or getting it through another method. So the attack on this was meant to restrict care across the whole country, not just in banned states, but in states that are supportive of abortion rights. And challenging the FDA approval was supposed to be a tool to wipe away this really important method of getting abortion for all of us across the whole country. Next slide. So the case has a bit of a history. I won't get into all the details, but basically activist, pseudo fake doctor, Judge Matthew Kaczmarek did earlier on do an injunction, which is where the court tells the defendant, in this case, the FDA, they either must or cannot do something. So originally mifepristone was found, he found that it should not have been approved, but that was just a very temporary holding. It was way out of line with judicial precedent, and therefore pretty quickly that was put on hold and made its way up to the Supreme Court. And that's where we are today. Just a couple of weeks ago, SCOTUS set forth its decision. The issues before SCOTUS included both whether the plaintiffs who brought the lawsuit even had a right to bring the lawsuit, and also those questions about did the FDA properly approve this. The lower courts had looked at both of those, but SCOTUS said, no, we're just looking at that initial question of whether the plaintiffs were able to bring this case at all. So they skipped all those discussions about the FDA approval process itself, and instead found that the plaintiffs did not have a right to bring this case. They did not have standing. Standing basically requires that if you want to bring a lawsuit about an issue, you have to show that that issue actually harms you. You can't just bring a lawsuit because you think a policy is bad. You have to show that it harms you. And so the doctors in this case had these very attenuated, weak theories that, oh, you know, someday someone might come to the hospital I work in who had a medication abortion and I don't want to help them. Like really stretched out. They had no evidence that they had actually been harmed or were going to be harmed. So the good news is SCOTUS acknowledged that that was not enough to bring this lawsuit. So for now, the case is mostly done. People in Washington and states all over the country where abortion is legal and where they don't have state restrictions can access mifepristone just as they could before. There have been no changes to the FDA's rules about how it's dispersed and distributed. So there are a couple technicalities I want to flag. One is that technically the case isn't totally over because some states, including Idaho, intervened and said that the mifepristone approval hurts them as states that are anti-abortion. And some of the language in the Supreme Court's decision kind of outlines theories that could happen in the future, not necessarily in this case, but in other cases where doctors or others who have a stronger basis to bring these claims will try again. So we aren't thinking that we'll never see a challenge to FDA rules again, but in this case, it's not going forward. There are a couple other kind of concerning things I wanted to flag about the case. One is that they talk a lot about conscience rights, which is where doctors may make a conscientious objection to providing basic types of medical care. And this is already a really problematic concept that we see in both federal and state law. And some of the court's language talked about it really expansively. And so we're watching for efforts for that to be expanded further. And we're worried we're going to see more instances where doctors and hospitals refuse to provide care under conscience rights and push that to be broader and broader. And then, as you may recall, earlier in the case, there was some discussion of the Comstock Act, which prohibits sending certain things across state lines, including abortion-related items. And so that was a pretty arcane theory. That's an extremely old law. The federal government does not think it applies in this case. But conservative activists are trying to bring it back and use it as a tool to attack abortion across the entire country. So it was mentioned before, perhaps because it's an election year, SCOTUS did not want to get back into it or talk about it, but we think that it will be raised in future cases as well. So that's the mifepristone case, and I'll pass it over to my colleague Alize to talk about EMTALA.
Thank you so much, Julia. I have the pleasure of talking about the EMTALA case that came down today, was accidentally leaked yesterday. It's been very dramatic for the Supreme Court lately. It's officially known as the Idaho and Moyle et al. V. U.S. case, more popularly known as the Emergency Abortion or Emergency Medical Treatment and Labor Act EMTALA case. So the Emergency Medical Treatment and Labor Act is a 1986 federal law that requires hospitals receiving Medicare funds to provide stabilizing treatment to anyone coming to the hospital with an emergency medical condition. Almost every hospital receives Medicare funds, and an emergency medical condition is defined as any condition that could cause serious impairment if not treated immediately, including pregnancy complications and miscarriage management. The state of Idaho bans abortion care, except when pregnant people are at risk of death. EMTALA requires treatment if people are at risk of impairment, including impairment of reproductive health, criminalized under Idaho law. This is why in 2022, after the Dobbs decision, the Department of Justice sought an injunction in Idaho to allow patients to receive emergency abortions. While SCOTUS decided to take the case, Idaho's draconian laws were in place, even in emergency circumstances. The question before the Supreme Court was, does EMTALA preempt an Idaho law that criminalizes most abortion in the state? Before going into the legal details of the procedural dismissal that the Supreme Court did, I want to talk a little bit about the environment in Idaho. As a result of Idaho's abortion laws, medical providers have found themselves having to decide between providing necessary emergency care to a pregnant patient and facing criminal prosecution from the state, or declining medical care and leaving a patient in crisis. Since Idaho's extreme abortion ban took effect, the state has lost nearly 1 in 5 obstetricians and gynecologists who have chosen to leave Idaho and practice elsewhere, which has led to hospital obstetrics programs around the state shuttering their doors. Next slide, please. So, as many of you may know, the Supreme Court this morning dismissed the case as improvidently granted. They dismissed this case on procedural grounds, and improvidently granted basically means they're saying it wasn't ready for the Supreme Court to take up in the first place. This means that the district court's preliminary injunction remains in place as litigation continues, meaning emergency abortions, when required, are permitted in Idaho. The Supreme Court basically delayed or punted, as this case will likely be before them again in a few years. The opinion itself was quite messy. There were 2 concurrences, 2 dissents, and justices were joining in part to the concurrences and dissents. So there was clearly no consent or overall consensus on what should be done about this case. One thing I do want to flag is from Justice Kagan's concurrence in the per curiam opinion today. She mentions that when the Supreme Court granted Idaho's appeal, they lifted the preliminary injunction, meaning no emergency abortions were permitted in Idaho. In that time, the state's largest provider of emergency medical services had to airlift pregnant people out of the state every other week. When Idaho did have to comply with NoHLA and provide emergency medical services prior to 2022, including abortion, that number was once per year. That statistic really puts in stark contrast the importance of access to basic medical care in all circumstances. And once again, highlights the importance of litigation and the impact of Supreme Court decisions on people on the ground. These are not just academic conversations or legal conversations, but opinions and decisions with impact on the ground in real life. And finally, I also want to flag that Washington has a state version of EMTALA called the Protecting Pregnant Patients Act that my fellow panelist, Leah Ruttman, will go into more detail later in the presentation. In the meanwhile, I'll pass it to Emily.
Thank you, Elise. Well, turning to another big case that hasn't reached the Supreme Court yet, but may be on the way, the Braidwood case challenges a core consumer protection of the Affordable Care Act, also known as Obamacare. For over a decade, most Americans have benefited from an ACA provision that says insurance companies have to cover certain preventive services with outpatient cost sharing, so deductibles, copays, coinsurance. And here's how that law has worked. The law refers to certain committees of medical experts, including the U.S. Preventive Services Task Force, or USPSTF, that's a mouthful I'm going to say several times, Advisory Committee on Immunization Practices, or ACIP, and clinical bodies related to the Health Resources and Services Administration, or HRSA. The law says that when these medical bodies designate certain services as important to preventive health care, then insurers must cover them without cost sharing. This law, as many of us know in the room, has been critical to healthcare access in the past decade. The Preventive Services Law is why we've gotten key services like contraception, immunizations, and screenings for STIs, depression, and common forms of cancer without paying out of pocket. But like so many pieces of the ACA, it's been politicized, has always been charged due to inclusion of contraception, of course, and became even more so after the USPSTF recommended that health plans cover pre-exposure prophylaxis treatment to prevent HIV for high-risk individuals, which is also known as PrEP. PrEP, as folks know, is a game changer for reproductive justice because it can reduce the risk of HIV transmission by close to 100%. But early use of PrEP showed disparities in access to the treatment, particularly in communities of color. So the broad USPSTF recommendation helped improve more equitable access. But not everyone's happy about that. After the PrEP guidelines took effect, a Christian-owned business and 6 individuals in Texas filed suit against the federal agency Department of Health and Human Services, challenging the preventive service law, claiming that, 1, the way the law is structured is unconstitutional because it relies on the recommendations of expert committees, and 2, the law violates their religious rights because their coverage must include PrEP. Turning to the next slide, please. Okay, so many twists and turns in this case, like the others. Like so many other cases attacking the ACA, this one started in Texas with our federal district court judge O'Connor, who's become famous for his conservative rulings against the ACA. And he issued a ruling in 2022 that was largely favorable to the plaintiffs, or the people who brought the suit, finding that first, the preventive services law we were talking about violates the appointments clause of the US Constitution because the federal head of HHS agency can't direct the US Preventive Services Task Force to recommend a specific preventive service. The appointments clause says that officers of the United States have to be appointed by the president and confirmed by the Senate. but the USPSTF was appointed by the head of sub-agencies within HHS. This gets pretty wonky. The court agreed with the plaintiffs that because of the expert clinicians of the USPSTF weren't nominated by the president or approved by the Senate, that there, in their estimation, was a constitutional problem with the law. Second, the court also found that the requirement to cover PrEP medications violated the rights of the plaintiffs who have religious objections to PrEP. Okay, so then in 2023, that same lower court judge, O'Connor, issued a ruling on the remedy for his findings, striking down a big part of the ACA's preventive services requirement on a national level. If it had gone into effect, Judge O'Connor's ruling would have stopped the federal government from requiring health plans to cover preventive services without cost sharing if they were recommended by the USPSTF after March 23rd, 2010. So many of those important protections that we talked about for preventive services would have been stripped away. Thankfully, the federal government appealed to the Fifth Circuit, which issued a temporary stay of the lower court's ruling, and that prevented the lower court's ruling from going into effect while the appeal was being heard. And court watchers, including myself, we all thought this might be on a fast track to the Supreme Court next year, but we see again some of those dynamics that we were just talking about. Oh, election year, maybe not. And instead, last Friday, the Fifth Circuit issued their ruling, and they affirmed or agreed with the lower court in part, saying that they agreed that the ACA's requirement to cover services without cost sharing, if recommended by that USPSTF expert body, is unconstitutional. So, But the Fifth Circuit also said nationwide remedy was not proper. The lower court ruling that would have applied this halting preventive services across the land was not appropriate. It should have only applied to the plaintiffs who sued. And not across the whole country. So that's good news, significant narrowing there. And then also sent the case back to the lower court to evaluate some factual questions related to the other expert committees. So once again, a bit of a sigh of relief. Where does that leave us? We're in limbo for at least another 1 to 2 years, or maybe more, as this case kind of goes back down and winds its way through the court. No broad impact for now, thankfully. But there is a possibility that we could see some copycat lawsuits from other Christian employees who don't want to cover particular services, of course. And thankfully, Washington passed a law last year that would protect all the preventive services for people in state-regulated plans, the plans that we can regulate as a state, but it doesn't insulate everyone in Washington from future effects because there are other plans that aren't able to be regulated by the state. So this is another one. Stay tuned. We may be hearing more from this case in the future. If we go to the next slide, please. We're going to talk more about Washington State, and we are in a much better place in Washington because of hard work of folks like our next speaker, Leah Rettman. Take it away, Leah.
Hi, all. So nice to be with you all today. We have spent a lot of time in this presentation talking about what's happening on the national level, basically because there's so much going on there. And all of it impacts Washington. But we're going to pivot a little and talk now about what's happening specifically in Washington State, where we both face some of the same problems that are occurring in Idaho and Texas. We're not totally insulated, but we've also worked really hard through our coalitions, with our patients, with our providers, to protect and expand access to both reproductive and gender affirming care in Washington State. There's still a lot of work to be done, but today I'm going to highlight 3 of the laws that have passed that do better protect Washingtonians as well as people who come here seeking care. Next to that slide, please. So I don't know about all of you, but when I hear about the EMTALA case that Eliza was talking about, I am furious. I am furious that we're in 2024 and we are having fights on the national level of whether pregnant people deserve access to emergency medical care. That is just something that should not be happening in 2024 or ever. Sometimes I think we have a tendency in Washington to think, oh, but that impacts other states, but not us. And unfortunately, denying pregnant people medical care is an issue that Washington State is very familiar with. In 2013, when I first joined the ACLU, many hospitals in Washington State were denying reproductive care to Washingtonians because they didn't want to provide abortion care, which, as Elise noted, is often the care that's needed when it comes to miscarriages and ectopic pregnancies. In 2021, the ACLU of Washington published a report working closely with patients and providers about pregnant patients who are being denied needed medical care here in our state. This included a hospital in Washington state delaying care for a patient who was miscarrying with heavy bleeding, incredible pain. Her OBGYN had advised that there was no chance of a viable pregnancy and that she needed treatment. But the hospital delayed care even after the pregnant woman became incredibly ill, all because of its opposition to abortion, which was the treatment needed. It includes a patient driving across the state, starting in Spokane, because after their water broke at 18 weeks and they were told their pregnancy wasn't viable and that they were at serious risk of developing a dangerous infection, they could not find a hospital that would treat them. And this includes the incredibly dangerous practice of delaying care for ectopic pregnancies, which are unviable pregnancies that can be life-threatening if left untreated. In one such instance in Washington state, the delay resulted in the patient's fallopian tube bursting and the patient being rushed to the emergency room. To address this issue, a big coalition of community organizations, patients, and providers worked together for years to pass the Protecting Pregnant Patient Act, which you see on the screen. What this bill does is it means that health entities like hospitals cannot prevent a willing medical provider, so like a nurse or a doctor who wants to provide that care, if failure to provide the care would violate standard of care, place the patient's health or life at risk. So again, we are still left with the concern Julia raised that the provider themselves can deny the care. The doctor can say, I don't want to provide that care in these emergency situations under this bill. But it does mean that our hospitals can't deny the care, which is what we were seeing occur time and time again in Washington state. So even if EMTALA is found at some point not to provide abortion care, which by the way makes absolutely no sense under the law, but even if it was, we do still have important protections in place in Washington state. And just this month, in anticipation of the EMTALA decision, which we just discussed, our Governor Inslee, issued a directive to have the Department of Health in Washington reaffirm, clarify, and enforce Washington state laws when it comes to hospitals' requirements to provide emergency abortion services. So unlike many other states, we do have additional protections as well as state agencies and individuals who want to ensure pregnant people have access to the care they need. I will say though, even the Protecting Pregnant Patient Act, which it just says, let's make sure pregnant patients get the care they need, was an incredibly difficult bill to pass. It took years and years and years, even in Washington state. So I can't even begin to imagine the challenges and pushback that people in, for example, Idaho are experiencing over the basic question of, I'm pregnant and I need emergency care. Why can't I get it? Next slide, please. So following the fall of Roe with the Dobbs decision, Washington state has passed many, many, many laws to protect and expand access to reproductive and gender affirming care, which, frankly is great. We are very glad that everyone in our state, many people in our state, are working together to try to protect and expand access to care. The first law I want to talk about is the Washington My Health, My Data Act. So this was passed in 2023 and was incredibly important because while many people think that the Federal Health Information Portability and Accountability Act, and I don't know why I ever read the whole name because it's the one thing that people actually know the acronym better, HIPAA, we all know HIPAA. While many people think that HIPAA protects all their private health data, it actually only covers data collected by specific healthcare entities, like doctors' offices and hospitals. Health data collected by websites and apps aren't covered by HIPAA, and so that information is left vulnerable. And you might think, well, that's not where I provide my health information. I provide my health information to my doctor at my hospital. So here's a few examples that My Health, My Data is meant to address. In May 2022, a data broker sold the aggregated location data of people who visited abortion clinics, including more than 600 Planned Parenthoods over a 1-week period for just $160. The data showed where patients traveled from, how much they spent at the healthcare centers, and where they went afterwards, including an analysis of where they lived based on where their phones were located overnight. This type of information is both creepy and very dangerous in the hands of anti-abortion activists and out-of-state actors who are trying to prosecute people for reproductive health care. Another example, and a scary one, was a teenager and her mother in Nebraska who were indicted in July 2022. And they were brought on multiple charges because the teenager had gotten an abortion using medication abortion and buried the remains. The mother's charges included violations of the state's abortion ban. In investigating the case, law enforcement went to Meta, so Facebook, and requested the daughter's social media messaging. And in that messaging, the daughter and the mother had communicated about the abortion pill. And so that information was used to help prosecute this mother and daughter, who were then sentenced to 2 years in prison for the mother and 90 days, I believe, for the daughter. So the Washington My Health, My Data Act is meant to better protect against these types of situations, protect against the unauthorized and harmful use of personal health data. It does a few things. So it prevents apps, websites, and other entities from selling and sharing people's health data without their opt-in consent or authorization. So you yourself have to say, yes, it's okay to share my data. It requires strong privacy policies that are public, and it allows individuals to later withdraw their consent and have that data deleted, which is incredibly important. Lastly, it restricts geofencing for the purposes of obtaining personal health information. And that sounds like a lot of words, but what we're talking about here is the situation of people's cell phone locations being tracked when they enter abortion centers, right? Trying to prevent against these type of situations. We are glad that this law passed in Washington State. It was the first of its kind, led by our Attorney General's office and many, many other advocates, including all that are presenting today. And we are now seeing other states across the country creating similar laws because they see the importance. The last law I want to talk about is our SHIELD law, which also passed in 2023. So our SHIELD law better protects people seeking, providing, or helping others obtain reproductive or gender-affirming care that is lawful in Washington State, including by preventing non-fugitive extradition, limiting Washington courts and law enforcement agencies' cooperation. What does that mean? What we're really saying is, for constitutional reasons, we cannot stop other states from conducting investigations or bringing their own lawsuits. We don't have that power. But what we can do is say Washington State will not cooperate, which is exactly what our SHIELD law does. And the example I'm going to give today is, unfortunately, we have already seen this SHIELD law be put to use in Washington. It's only been a year since it's passed, and already it's been needed. And that has to do with the provision in our SHIELD law relating to businesses. So we're saying law enforcement, you can't cooperate. Courts, you can't cooperate. And also, if you are a business, incorporated principal place of business in Washington State, and you provide electronic communications, let's say email, then you, entity, cannot provide information to someone from law enforcement issuing you a warrant, asking for your information, unless they can show through an attestation, so through a signed document, that this request for information has nothing to do with a lawsuit, with an investigation into reproductive or gender-affirming care that's legal in Washington State. Again, a lot of words, but it's really saying, hey, Google, you cannot provide information when Texas comes and asks for it unless they can show you this has nothing to do with them trying to prosecute someone who came here to get an abortion, right? That is what we are trying to accomplish here. And it showed up at Seattle Children's Hospital in Washington State, Texas being the example. So the Texas Attorney General, in I believe November 2023, so really just happened, demanded information from Seattle Children's Hospital relating to the care they were providing, gender-affirming care they were providing at Seattle Children's to people who are from Texas. So the kids were from Texas, but all the care was provided in Seattle. The Texas demand included a request for information about medical treatment, the number of children who were treated, the diagnosis, medications prescribed. It was really extensive and scary. In response, Seattle Children's filed a lawsuit in Texas court. And along with making jurisdictional arguments, constitutional arguments, they argued that Washington State's shield law, because of this business requirement, precluded Seattle Children's from complying with Texas's demands. They were not allowed to provide it because our shield law says they cannot. And almost immediately, our Attorney General filed a complaint and a consent decree with Seattle Children's. So basically, Seattle Children's and the AG's office filed an agreement together with the court saying Seattle Children's won't be providing this information because they can't provide it under Washington state law, including our shield law. Ultimately, the Attorney General in Texas dropped the request, and that information was not provided to Texas. I think that's just one example of why we need to be super proactive in passing really strong laws in Washington state. There are still loopholes and other things we need to pass. One example is electronic health records. Some other states are working to segment those. So to ensure that if you come here for an abortion, that information isn't then available at your Texas doctor at your next appointment. Things like that haven't been done in Washington state. There are many other laws and protections that still need to be put in place, but I think our state has made a really strong start and has clearly indicated through all the providers, through the patients, through the community advocates, that there is a continual desire to protect and expand access here. Next slide.
Thank you, Leah. I'll take it from here. You brought me so much optimism, and I'm sorry to dampen the mood a little bit by talking about Initiative 2081. But it's really helpful to see these next to each other because, as Leah just highlighted, our state is doing so much to protect access to care, and that reflects the will of the voters and the legislators. And what's really unfortunate is Initiative 2081 goes in the opposite direction in some ways. And it is able to do so because it's very confusing. And so I will get into that a little bit. Initiative 2081 was one of 6 initiatives put forth by conservative activists in Washington state for this cycle. But before they go to the voters, they have the opportunity to go to the legislature. And so 2081 and a couple others actually got passed by the legislature. So you won't see it on the ballot. It's already law. And Initiative 2081 does not look like it has to do with healthcare. It looks like it has to do with schools, and that's because it is focused on public schools, and it's framed as a parent's bill of rights. It sets out 15 rights for parents of public school students. Some of them are really duplicative with existing protections or existing practices. For example, it says parents have a right to see the school calendar posted on the website. You know, some of it's really simple stuff like that. But hidden in all of that are a couple things that are quite concerning. So one thing the initiative does is it expands parents' rights to access education records and defines that to include health records, including mental health records. So there are instances where youth might talk to a nurse around mental health issues, and now their parents can get that, any notes, etc., through a records request under 2081's new rules. It also requires schools to notify parents if the school offers or arranges, even indirectly arranges for healthcare, which could be construed pretty broadly to cover things like referrals and other forms of healthcare information sharing between nurses and students. And why this is so concerning is that this undoes a lot of really important protections that have been in state law for a very long time. So in Washington, minors, once you're 13 or older, you have a right to get mental health care without your parent being notified, without your parent's consent, without your parent seeing the notes from your provider. And that confidentiality is essential to making young people feel safe to get that help that they need. And so similar rules exist around mental health, behavioral health, if folks are battling some sort of addiction issue, sexual and reproductive health care. There are a lot of strong confidentiality rights for youth in Washington, and this really undermines them if those healthcare services in any way touch schools, conversations between students and teachers, conversations between students and nurses. The initiative does a couple other concerning things. It undermines protections for youth seeking shelter care who have reasons that they wouldn't be safe if their parents are notified. So some great recent legislation through a lot of community advocacy set up protections for youth in those instances. And this law undoes a lot of that by creating new notification requirements where the schools have to contact parents. So that's harmful to youth. And then it's also broadly harmful to education quality in Washington, especially the ability of educators to provide inclusive education, inclusive curriculum, which again is required by law. This undoes a lot of that by allowing parents to opt their students out of discussions and activities that touch on things like morality, sexuality, mental health, all these topics that are so important to making LGBTQ students, BIPOC students feel seen and appear in the curriculum and the classroom conversations. It's hard to talk about civil rights history or public policy without touching on morality. It's hard to talk about student well-being without touching on mental health. All these things are going to be more challenging because of some of these new notice and opt-out requirements. So because of all these concerning parts of the Parents' Bill of Rights, Legal Voice, ACLU of Washington, and Q-Law are representing a broad coalition of plaintiffs who are challenging Initiative 2081 in court. The good news is that we partially won a preliminary injunction last week. So the parts of the law related to healthcare privacy are put on hold, and some of the other parts of the law related to the administrative burden on schools for responding to these types of requests have been put on hold. And we challenged it under a kind of obscure part of the Constitution that basically says if a law is going to change existing laws, it needs to state those amendments clearly. And while that sounds very boring, this is a perfect example of why we have that rule. And it's that you could read the initiative and have no idea that it makes it harder for teenagers to safely access healthcare or to safely talk to a trusted person at school about their mental health needs or their sexuality or all these things that they might not be ready to talk to a parent about, but they definitely need support and access to care. And this really has undermined their ability to go to schools for that kind of support. So the case is ongoing, and we'll keep you updated.
So we can move to the next slide. And one type of care minors can receive without parental consent in Washington is contraception. And the good news is that the United States has finally joined over 100 other countries around the world to allow over-the-counter access to birth control. However, while Washington's Reproductive Parity Act went into effect in 2019, the reality is that most Washingtonians don't know that their health plans are required to provide coverage for all contraceptive drugs, devices, and other products covered by the FDA. It's important to note that that coverage may not require co-payments, deductibles, or other forms of cost sharing, and cannot require a prescription to trigger over-the-counter coverage of those. However, the law is one thing, reality often presents some obstacles. In the last 6 years, the layers of complexity around medical insurance and payment systems have prevented people from accessing over-the-counter contraception. While Opill did hit retail shelves this March, every insurance company has its own process. Every pharmacy chain has its own payment system. And those payment systems expect a national provider number. So while the Reproductive Parity Act intended to provide over-the-counter contraception without cost sharing, the reality is a NoHLA intern made over 100 calls to pharmacies this spring, and not a single one correctly said, yes, your private insurance will cover over-the-counter contraception without cost sharing. Now, our state Medicaid agency did issue guidance for the 5 managed care organizations, so a handful of pharmacies did say, if you're on state insurance, you can access, but only a single pharmacist said, you could do that at my prior pharmacy, but we don't have a system to do that here. This reality is why 17 organizations called on Governor Inslee, Commissioner Kreidler, and Secretary Shaw to take action and meaningfully implement this law from 2018 so that we can all access contraception the way we're supposed to be able to under state law. We've asked for a standing order and more robust regulatory enforcement. We haven't heard back yet, but we will continue to use every tool at our disposal to fight back against attacks on our bodily autonomy. And so on that note, I want to make sure we have a little more time for questions. So I think Julia is planning on answering our first question, and we can go to the next slide.
Great. Thanks, Lychee. So there was a question in the chat going all the way back to the mifepristone case about what this means for Attorney General Ferguson's case to expand MIFI access. This is a little technical procedure-y, but hear me out. So the Washington Attorney General, along with other states, brought an action against the FDA, which was challenging the most recent FDA decision about the restrictions on use for mifepristone. As I mentioned before, they've generally been making it easier and easier to access mifepristone, but the FDA has not gone so far as to treat it like a whole bunch of other medications that are honestly less safe than mifepristone, but don't have a whole bunch of restrictions. Mifepristone is extremely safe, but the FDA continues to have this extra layer of restrictions in place. So Washington was challenging those lighter level of restrictions. And one of the goals was to make sure that any decisions coming out of the Texas case aren't harming people in Washington and the other plaintiff pro-abortion access states. And so the court put an injunction in place that said the FDA could not change the status quo and reduce access to mifepristone in Washington and other plaintiff states. That happened a while ago, and the court has basically put on hold further discussion in that case until the Supreme Court decision came down. So now that the Supreme Court decision is out, the parties there will update the court on when and how to proceed with the case, including potentially summary judgment, where they would argue to the court on their various issues. So I can't speak to the Attorney General's office plan and strategy about that, but that's where it stands from a civil procedure point. There's also an issue in that case where Idaho and some other anti-access ban states have tried to intervene, and the court had denied that, and that's on appeal to the Ninth Circuit. And again, that might be informed by the case that just came out. Hopefully that answers your question, Nicole.
Thank you, Julia. Leah, I was hoping you could, there was a question in the chat about, or in the Q&A about how data brokers get people's information to be able to sell it. And I know it was specific to the cases you were talking about, but if you could just in general talk about how data brokers access our information and how they share them, that would be great.
Yes, I'm happy to. I provided a little information in the chat, but the idea here is when we download apps, for example, a specific weather app, a specific really app about anything, often we don't realize that sometimes those apps are tracking our location. And that information can then be sent to data brokers. So often when we're just like walking around with our cell phones, our location data can be tracked from some of the apps we have being used on our phones. And wanted to provide that information.
Thank you so much, Leah. Lychee, do you want to take the question around contraception in the Q&A? We have about 4
Sure. I mean, I think if you have a chance to ask our gubernatorial candidates, ask them what they're doing to meaningfully provide contraception access in Washington, because we all know there's this disconnect between the law and people's real life experience. So you can ask if folks running for governor support a standing order. You can also ask if they have other ideas. The insurance commissioner position is also open. So you can ask folks running for that office how they plan to make sure that OIC does a better job of enforcing regulations to make sure people have meaningful access to contraception. I'd start there.
Thank you so much. Once again, all of our contact information is available on the screen. Please reach out. Happy to chat one-on-one about my feelings about the NoHLA case, or anything else we've covered today. And to learn more about our organizations, all of those links are also available. So with that, I hope everyone has a good afternoon. Thank you.
Thank you.